Good morning, everyone. This is Wang from Shandong University. It's my great honor to be here to present our study on behalf of our study group. Today, I will talk about a topic on radiotherapy after breast conserving surgery for elderly patients with early-stage breast cancer. This is a national registry-based study. Authors had declared no conflicts of interest. I will start with some brief background. As we all know, since 1989, breast cancer death rate has declined dramatically in the past 3 decades, and this decline in death rate is greatly attributed to the improvement of comprehensive treatment of breast cancer, including surgery and radiotherapy. However, we also know that for elderly patients, that means patients older than 75 years old, the improvement of survival is not that evident as the younger patients. As to breast cancer surgery, we have known that breast conserving surgery plus radiotherapy has become a standard treatment for early-stage breast cancer, particularly for patients with small tumors. As to this treatment, we have several things known for sure. The first thing we know for sure is that breast conserving surgery plus radiotherapy is at least equivalent to mastectomy in terms of survival outcomes. This has been confirmed in both clinical trials and observational studies. The second thing we know for sure is that radiotherapy following breast conserving surgery is essential in the general populations. Studies have shown that radiotherapy reduced cancer recurrence by 50%, reduces breast cancer deaths by 20%, and the risk of all-cause deaths by 10%. However, because the reduction in risk of recurrence is larger than the risk of death, it is proposed that radiotherapy may be omissionable in some selected low-risk populations. The clinical trial 9343 is the first study that defined such low-risk populations. In this study, we saw patients aged over 70 years old with T1 ER positive cancer and those who received endocrine therapy. Radiotherapy in these patients resulted in somehow lower 5-year and 10-year local recurrence, but resulted in quite similar overall survival. So this study showed that in some selected low-risk population, radiotherapy may be omissionable, and this finding has also been confirmed by another trial, Prime 2 clinical trial. However, to date, there are still some controversy on radiotherapy after breast conserving surgery. On one hand, the guidelines differed across different guidelines. For example, for NCCN guidelines since 2004, NCCN guidelines have recommended that we may consider omission radiotherapy in some selected population as defined by clinical trial 9343, that is, patients aged over 70 years old with T1 ER positive cancer and received endocrine therapy. However, as recommended by USOMA guideline, we still said radiotherapy should be considered in all older patients. On the other hand, the changes of NCCN guideline recommendation resulted on only little impact on clinical practice. We can see the data from US show that the rate of recommendation for radiotherapy post-breast conserving surgery resulted on only slightly decline in the past 10 years from 70% in 2000 to 67% in 2009. And also there are some observational studies show that omission of radiotherapy after breast conserving surgery was associated with worse overall survival. Also, it's worth to mention that the radiotherapy techniques have been improved dramatically in the past 10 years. So besides omission of radiotherapy, we also talk about some de-escalation tragedy of radiation. So based on this background, we conducted this study to evaluate whether radiotherapy after breast conserving surgery could be safely omitted in elderly patients with early-stage breast cancer in the real-world clinical practice. In addition, if yes, which population could be the best candidate? To conduct this study, we use the National Cancer Database to perform our analysis. NCDB is a registry-based database. It including information of patients from 1,500 hospitals covering over 70% of newly diagnosed cancer cases across the United States, including 2.5 million breast cancer patients. Was mentioned in this database, it collected detailed information on some demographic variables such as region and facility type. It also had detailed information on some biological characteristics such as tumor stage, ER, PR, HER2 status, and it reported some treatment information like chemotherapy, endocrine therapy, and there are also some information on access to care variables such as income, education, and insurance type. So this is a good resource for study. In the topic I presented, we identified 2.5 million patients in this database. Of all these patients, about 1.8 patients were diagnosed with primary breast cancer. And we excluded patients who had positive margin after breast conserving surgery, those who received neoadjuvant treatment before surgery, and we also excluded patients who died within 90 days after surgery or who had no complete information on follow-up before 9 days post-surgery. After this inclusion and exclusion screening, we had 115,000 patients for the primary analysis. Among these patients, we can say there are almost 30,000 patients did not receive radiotherapy, while about 84,000 patients received radiotherapy. Okay, as shown in the left panel, we also note that among all these patients included for final analysis, there are about half patients met the NCCN guideline criteria for omission of radiotherapy. So in our analysis, we will focus on these two populations. In our study, our study endpoints was 5-year mortality. Because in NCDB there is no information on recurrence or breast cancer specific death information, so we also conduct some landmark analysis, that is 3-year or 10-year mortality as an alternative. In this study, we evaluated the crude survival difference between two groups using the log-rank test. We also estimated the association between radiotherapy and total mortality using the multiple variable cost proportional models. To account for some potential selection bias or some other bias, we also conducted a series of sensitivity analysis, including the propensity score weighted analysis, and we also conduct some stratified analysis by the comorbidity status, because this is an important factor for the decision of radiotherapy or not. We also conduct some analysis by excluding patients who did not receive radiotherapy just due to some certain contraindications. So here I will move on to the results of our study. As shown in the left panel, you can see among the 115,000 patients including for and final analysis, almost half patients met the NCCN guideline criteria for omission of radiotherapy. Among these patients, almost 23.6% of patients did not receive radiotherapy at the last. And as shown in the right panel, you can see before 2008, as shown in the blue line, the rate of omission for radiotherapy remains quite stable, but gradually increase afterwards. It can see from almost 25% in 2010 to almost 30% in 2014. However, if we stratify our analysis, we can see that the trend of increase of rate of omission overall was only evident among patients who met NCCN guideline for criteria for omission or radiotherapy as shown in the green line. In this table, we can see the baseline characteristics of our study population. We can see, compared to people with radiotherapy, the people who do not receive radiotherapy are, in general, about 3 years older. But if we stratify the patient by every 5-year age group, we can see the age is quite close within each age group. This is also true for the patients who met NCCN guideline criteria, that means NCCN eligible patients. Also, we noted that compared to patients who did not receive radiotherapy, the people with some smaller tumor, that is T1 and 0 tumors, who had ER or PR positive tumor, HER2 negative tumor, grade 1, or no LVI invasion tumors are more likely to omit radiotherapy, and also noted that people with comorbidity are more likely to omit radiotherapy. Also, people who received radiotherapy after breast conserving surgery are more likely to receive chemotherapy as well as endocrine therapy. So the survival analysis showed that the patients who received radiotherapy after breast conserving surgery had better 3-year, 5-year, and 10-year survival, and the absolute survival differences at 5 years is almost 13%, with better survival than in the patients group who received radiotherapy. And this is true, as shown in the right panel, is true for the patients who fully met NCCN criteria for omission or radiotherapy. And we further conduct some analysis by the age groups, as shown in this slide. We can see in the entire study population, the survival differences remained for every 5-year age groups. And this is also true when we restrict our analysis within NCCN eligible population. So after adjustment for ages, for biological characteristics, and some treatment information, as well as some access to care information, we also noted that in both entire population as well as in NCCN guideline eligible population, radiotherapy post breast conserving surgery resulted in almost 60% lower risk of total mortality in 3 years and almost 50% lower risk of 5-year mortality. This is also true for NCCN guideline eligible population, and this association pattern is quite consistent when we restrict our analysis within each 5-year age groups. Also, besides the NCCN eligible patients, we also noted that within or among NCCN eligible patients, that means people did not fully met the NCCN criteria for omission or radiotherapy, either for the tumor stage or either for the ER status or for the treatment of endocrine therapy. We also noted that for these ineligible patients, the association pattern between radiotherapy and the total mortality was quite stable or quite consistent with those patients who met NCCN criteria. And this association pattern persisted irrespective of the tumor state, the ER status, or the endocrine therapy status. As we all know, the comorbidity status or the health status is an important factor that may affect patients' decision for radiotherapy. We conducted some analysis by comorbidity status in this study. Comorbidity was estimated using a Charlson score, with a score of 0 indicating no comorbidity. As shown in this table, we can see that in both entire population as well as in NCCN guideline eligible patient population, the association between radiotherapy and total mortality, even 3-year, 5-year mortality, was quite consistent across different groups of comorbidity. And we further evaluated whether this differed across patients within different reasons for no radiotherapy, and we found that this association pattern was not changed by the reasons for patients why they did not receive radiotherapy. Also, this pattern did not differ by some biological subgroups and treatment subgroups as shown in this. For its plot, we can see the estimated points were quite stable across different subgroups. What to mention, we focus on the reason for no radiotherapy. We found that people who did not receive the radiotherapy because the contraindication in this group of patients, the estimate point is much higher. It's 2.3. So we conduct some scientific analysis by excluding these patients who had contraindications and did not receive radiotherapy, and we found that the association pattern did not change a lot in the entire population as well as in guideline eligible population. So this is further confirmed the robustness of our findings. To account for some potential selection bias, we conducted further propensity score weighted analysis, and in this table found that so the associated pattern still is quite stable and more or not essentially changed. Even despite the 18 points is even a little slight higher or larger than those observed in the primary analysis. So in this study, we have some strengths that is large sample size, the general reliability, and we have multiple prognostic and social demographic factors included in the adjustment. Also, there are some limitations in our study because we do not have some information on recurrence, and we acknowledge the potential selection bias because this is a registry retrospective study. So based on this study, we conclude that reconsideration may be needed for omission of post-breast conserving surgery as a routine practice for elderly patients with early-stage breast cancer, and more research is needed to evaluate the influence of cancer characteristics, physical characteristics on long-term outcomes. As well, we need to identify prognostic biomarkers to provide a personalized approach for radiotherapy recommendation in these elderly patients. This study was led by Dr. Zhao Shu from BUMC, and we acknowledge Dr. Yu from Shandong University. Also, I was supported by CSC scholarship for this study, and also this study has been accepted for publication in International Journal. That's all I presented today, so thank you all for your time.